Good evening, doctors. Welcome again in the fourth session of 52 weeks long module on diabetic essentials by Padam Shree Dr. K.K. Agarwal sir. In last three sessions, Dr. Agarwal has completely transformed the way doctors used to look at diabetes. His phenomenal practical tips and simplistic way of explaining the complex topic has made this whole program more interesting. And today's session is inflammation causing diabetes, and I'm sure sir is going to give us even more in-depth information. Before handing over the session to sir, I would like to announce the answer of last quiz that happened last week. The question, I'll read it out. The question was: hyperinsulinemia may be caused by all the following except the options were option A, an insulinoma, option B, necidioblastosis, option C, insulin resistance, and option D was type 1 diabetes. So the correct answer to the question was option D, type 1 diabetes. Uh, Now I would hand over. I request Dr. K.K. Agarwal sir to start the session, sir.
Thank you, Shalim. Before I go to the topic, let me explain a term which all of you, the last question which the results have been announced, necidioblastosis. It is a medical term for hyperinsulinemic hypoglycemia attributed to excessive insulin production by pancreatic beta cells. So जब आपको इंसुलिन बढ़ जाता है, नॉर्मली जब इंसुलिन बढ़ता है तो शुगर भी बढ़ता है. So when you have high insulin, you also have high sugar. That is called as a metabolic syndrome. But when your insulin levels are high, but you have low sugar, that is called necidioblastosis. So that was, people were confused. They were asking that we have not heard about this condition. Therefore, I thought to explain this condition. Today's topic, we are going to talk about inflammation, low-grade inflammation. So let me pick up the slides. So this is fourth in the series, Diabetes Essentials, 52 weeks. This is the fourth week. And topic we are talking about inflammation and diabetes. So this inflammation, we are shifting from a community treatment to person-centric treatment. Every individual may have a different inflammation. Therefore, when we talk about person-centric treatment, I ask my patient, when we say, is he diabetic? Then we say, is he inflammatory? And second thing we say is, if he is inflammatory, is he diabetic or not? So therefore, we are talking about a pro-inflammatory and pro-coagulative state of the body. Now, there has been two paradigm shifts in understanding diabetes. There was a time when I was a medical student, diabetes meant high blood sugar. In fact, it was not even high blood sugar. It used to be sugar present in the urine. Because at that time, blood sugar was not available. It was a test not easily done. And we used to do a Benedict's test to detect diabetes. So the definition of diabetes used to be blood sugar in the urine. And people used to say that the urine contains sugar, therefore ants are coming, therefore the person has diabetes. So the first paradigm shift came that it shifted from sugar in the urine to sugar in the blood. Remember, now sugar in the urine has no value. The sugar in the urine has no value because SGLT2 inhibitors causes sugar in the urine. So there was a paradigm shift. Diabetes meant sugar in the urine to sugar in the blood. Then there was a paradigm shift that don't only you treat sugar, but also treat blood pressure and cholesterol. So the paradigm shift came was A, B, C. That means you control the A1C, but also control the blood pressure and cholesterol. This was in early 90s when we started controlling ABC of diabetes. Then came the control of macro and macrovascular complications. We started looking for proteinuria, microalbumin, we started looking for retinopathy, and we came different types of UKPDS trial came, and many trials came, and we started talking about strict control of microvascular disease. We used to say that if your blood sugar is strictly managed, you prevent microvascular complications. But still, macrovascular complications were managed only by BP and cholesterol. Then came that you also control associated risk factors to reduce chances of sudden death. And there came the role of smoking, exercise, and other things. The latest is ATP3 guidelines when it came metabolic profile. They said that you don't wait for the sugar to become high. If your A1C is more than 5.5 or less than 6.5, it is metabolic syndrome. If your HDL is less than 40 in male and less than 50 in female, if your triglyceride is more than 150, if your blood pressure is more than 130/80, if your sugar is more than 100, this is the person has metabolic syndrome. Treat that. And now we have come back to controlling the inflammatory markers and endothelial markers with controlling the procoagulative state. So for the first time, we are talking about controlling the macrovascular disease. So when you control blood sugar tightly, you control microvascular complications. But the sugar is not controlling the macrovascular complications, which are penile vascular disease, peripheral vascular disease, carotid vascular disease, and coronary vascular disease, and diabetic atherosclerosis. So today we are going to talk about the total answer of diabetes, because if I control inflammation, I control the basic pathogenesis of diabetes. The root cause of diabetes, if I control, then I will be able to control both macrovascular and macrovascular complications. And I'm calling it as a paradigm shift. That means whenever you are managing a patient with diabetes, always look for how do I control the basic underlying inflammation. Now, how do I know that my patient has a inflammation in my body? This inflammation now is called metabolic inflammation. In short term, it is called meta-inflammation. Meta-inflammation, metabolic inflammation is somewhere in my body, I have excess of fat, which initiates meta-inflammation, which ultimately ends up with diabetes. So we are talking about normal waist, normal BMI, obesity. So we are talking about normal weight obesity. We are talking about visceral obesity. We are talking about pot belly. So all these situations in inflammation is the root cause of development of diabetes and insulin resistance. How do I pick up clinically? Any weight gain after the age of 18 in women and more than 20 years of age in men, if the weight gain is more than 5 kg, which is for the muscle strength, is nothing but fat. So excess of fat in the body is not going to lie ideal. So if I have a weight gain of more than 5 kg after the age of 18/20, take it for granted I have excess of fat in my body. If I have obesity at age 7, which continues till the age of 12, take it for granted if you are an adult today, you have excess of fat in the body. If your BMI is more than 21 kilogram per meter square, take it for granted you have excess fat in the body. So therefore, there is another paradigm shift number two. Treat the patient and not the sugar. So therefore, now we say treat the inflammation and the sugar. It is a person-centric treatment. Now remember four things in obesity and diabetes. Obesity or excess of fat will cause something. That something is called meta-inflammation in four areas. So if you eat extra fat, suppose I eat extra fat and because of that I have extra fat in my body, these fat will cause inflammation in four areas. Liver, it will cause fatty liver. Muscle, it will cause muscle inflammation. Adipose tissue, it will cause obese adipose cells, which is now an endocrine system, and it will cause inflammation in the pancreas. Remember, whenever there is an extra fat in your body, you need to look for these four things. They are interconnected with each other. Fatty liver, we don't wait, we don't correlate it with diabetes. Muscle, we don't bother. We never talk about muscle strength in patients with metabolic syndrome. Adipose tissue, we don't treat. Pancreas, we don't treat. We only treat the blood sugar. So normally we have been treating the blood sugar. We have not been evaluating inflammation in the liver, muscle, adipose tissue, and pancreas. Today, at a metabolic syndrome phase, the main treatment of blood sugar and prevention of blood sugar is muscle strengthening. If you strengthen your muscle twice in a week, your metabolic syndrome may disappear. But nobody is talking about that. That weight lifting, weight strengthening exercises can improve my muscle inflammation. So remember, the paradigm shift is treat the patient, treat the inflammation, and person-centric means evaluate a patient for liver, muscle, adipose tissue, and pancreas. These four will be involved much before diabetes happens. So inflammation will lead to involvement of liver, muscle, adipose tissue, and pancreas, which will lead to either deficiency of insulin because of inflammation of beta pancreatic cells or insulin resistance because of inflammation in the liver, muscle, and adipose tissue. Now see what happens is the first mechanism of low-grade systemic inflammation. Remember, this is called low-grade systemic inflammation. It is not a local inflammation. Is the inflammation of white or visceral adipose tissue. So the first will be that my cell, visceral cell, will become obese. You can see in the slide, the cell becomes obese. So fatty acids enters the cells. When this cell is occupied by the fatty acids, other cells and components of the cell will get suffocated. Remember, two things are happening, that my body has been occupied by strangers called fatty acids. Because of that, other parts of my cell will get suffocated and hypoxic. They will not get the blood supply. So adipocytes accumulate large amount of fatty acid inside them. There are hyperplasia and hypertrophy. The cell number increases and they become hypertrophic. And they start showing hypoxia and necrosis. The cell will start dying because they don't get blood supply. And a dying adipocyte, a cell which is dying, will initiate macrophages. And these macrophages will produce TNF alpha. So two things I will talk again and again. While in corona we talked about IL-6, less of TNF alpha. In obesity we talk about more of TNF alpha. TNF alpha, TNF alpha, TNF alpha, and macrophages 1, 1, and 1. So there are two types of macrophages, macrophage 1 and macrophages 2, which we will talk. So what happens is now this cell is hypoxic. Some of the cells have died. These dying cells or the cells which are dead, these dead cells will attract macrophages. And now this dying cell becomes like a non-self, initiates a inflammatory process. And this inflammatory process will occur in the adipose tissue, in the liver, in the muscle, and in the pancreas. So this is called meta-inflammation, that is metabolic inflammation. New terminologies. So whenever you want to impress your patient, come back with a new diagnosis. You start saying, oh my God, you are having meta-inflammation. The patient will say, this doctor knows so much. So pro-inflammatory cytokine is TNF alpha. Remember, the main is TNF alpha. Remember, TNF alpha is present in curcumin, which is haldi. So therefore, curcumin reduces meta-inflammation in diabetics. So TNF alpha induces insulin resistance. Now remember that in a normal circumstances, you have M2 macrophages. M1 and M2. M2 macrophages produces IL-10 and they are anti-inflammatory properties. But these M2 macrophages convert them into M1 macrophages when they find the cell is dying or a dead cell is there. Because it is M1 macrophages which can take care of and dispose the dead cell of adipocyte. So remember now two things, M1 macrophage and TNF alpha. So these things too have to remember when we understand macrophages, because later on when we talk about treatment, we will talk about anything which reduces TNF alpha may reduce the inflammation of diabetes, and anything which reduces M1 macrophages and increase the M2 macrophages will improve the diabetic inflammation. Now, what is the difference between normal inflammation and low-grade systemic inflammation? Classical inflammation means CRP more than 10. Low-grade systemic inflammation means CRP less than 10. The classical inflammation is acute. Low-grade inflammation is chronic. Classical inflammation is always local, pneumonia, cellulitis, abscess. And low-grade systemic inflammation is always systemic, and it is present on insulin-dependent tissues. Remember, low-grade systemic inflammation will be present in insulin-dependent tissues, including the liver, including the muscle, including the adipose tissues. This is where, and the pancreas. It contains macrophages and T lymphocytes predominantly, and tissue injury is absent, and low-grade systemic inflammation is responsible for dyslipidemia, atherogenesis, diabetes, and systemic arterial hypertension. Now you understand that there was a paradigm shift. The paradigm shift was treat the blood pressure, treat the diabetes, treat the cholesterol, and now we say all three of them are because low-grade systemic inflammation. Therefore, now we say treat low-grade systemic inflammation, and you will automatically treat dyslipidemia, atherosclerosis, hypertension, and diabetes. Now what happens? When I say adipocyte death leads to hypoxia, hypoxia will lead to mechanical stress, mitochondrial stress, and it will lead to an inflammatory response. So there are two types of inflammatory responses which will happen. One will be macrophage-induced TNF alpha, and second will be a oxidation stress, which will lead to the cell injury. So two pathways comes in, oxidative stress pathway, and the second is TNF alpha pathway. For this oxidative stress pathway, the role of antioxidants will come as a anti-inflammatory. So therapeutically now we have said something to reduce TNF alpha, something to reduce oxidative stress, which is antioxidants, and the third will be something to reduce my macrophages 1 and increase the macrophage 2. That's what I want things to happen. Now here you can see macrophage 1 is converted into macrophage 2. That's what your normally a macrophage 1 should convert into macrophage 2 for healing. But if macrophage 2 converts into macrophage 1, it means it's a disease. Now what happens in this slide, I will come back again. So let me come back to this oxidation will lead to autophagy with possible apoptosis of the cells, and it will also increase leptin levels and reduce the adenopectin levels, which we will come back. So remember, in diabetes, three things are happening. One, there is TNF alpha response leading to inflammation, which causes damage, which causes cell destruction. Second is oxidative stress, which causes mitochondrial DMA damage, and that is the site for intervention. And the third thing, it increases leptin and reduces adenopectin. Leptin is also an inflammatory compound, and adenopectin, if you increase, the diabetes inflammation reduces. So we have now another two segments, that something which can reduce the leptin or increase the adenopectin will also reduce diabetic inflammation. Now this is something it talks about different types of pathways. So now there is a low-grade systemic inflammation in the adipose cells in four areas: in the pancreas, in the liver, in the adipose tissue, and in the muscles. In the muscle, it will lead to insulin resistance, and in the pancreas, it will lead to beta cell destruction. There are different pathways. I'm not going into the detail of these pathways. We will discuss in one of the sessions when we talk about the treatment of inflammation. Today, we are only talking about the pathogenesis of inflammation. So involvement of adipose tissue, muscle, and liver ultimately will lead to systemic insulin resistance, and inflammation in the pancreas will reduce insulin production. So therefore, there are two types of drugs: increase the insulin production or you improve the insulin resistance. But now we are talking about the baseline. You treat low-grade systemic inflammation so that insulin increases and insulin resistance doesn't come. So therefore, that's the paradigm shift. Now in liver, adipose tissue, and muscle, it uses TLR, toll-like receptors and nod-like receptors. So in a cell, when you enter a cell, you have to pay a toll tax, and that is called toll-like receptors on the surface. And if you bypass the toll tax because the toll tax person was corrupt, you enter inside the cell, then nod-like receptors takes over. So these nod-like receptors, inflammation is on pancreas. All other places, it is toll-like receptors 2 and 4, which causes the disease. Nod-like receptors is NLRP3 pathway, mefenamic acid, colchicine, calmake, tricatu. All these things works at the level of NLRP3. So now we have got another angle. So first of all, reduce TNF blocker, TNF alpha. So I need some natural drug or something to reduce TNF alpha. The second thing I need is to reduce NLRP3. The third thing I need is something to reduce my leptin, or I need something to increase my adenoleptin, or I need antioxidants. They in combination or alone will be able to manage my inflammation. But we are forgetting the most important thing, and that is low grade systemic inflammation is also caused by refined carbohydrate. Sugar is a slow poison. So when you take excess of fat, which is excess of energy, which is converted by the sugar, it will be converted and stored like a fat. And there comes the role of Energal Zero, which is a anti-inflammatory drink, rehydration drink with 5 vital electrolytes. So what happens is, if you want to refresh yourself, you have to take a drink or a food which does not have refined carbohydrates. That will also reduce low grade systemic inflammation. So we have talked about 6 interventions to reduce low grade systemic inflammation. Now, what happens in the liver? Now we will go one by one quickly. Inflammation in the liver, adipose tissues in the liver will cause CRP more than 2. What happens in the liver? The Kupffer cells are not affected, whereas the accumulation of monocyte-derived recruited macrophages increases several times, leading to inflammation, which is a macrophage, monocyte-derived macrophages pathway, and which is because of TLR2 and TLR4 pathway. In the muscle, it causes chronic muscle inflammation. So there is a muscle weakness. It triggers the inflammatory pathways. Therefore, muscle building exercise becomes a must to reduce the inflammation. In the pancreas, it uses the NLRP3 pathway using the kappa beta nuclear factor pathway, and therefore it ends up into beta cell destruction. Therefore, to save the pancreas, we need some drug which reduces inflammation at the level of gamma interferon, TNF alpha, and NLRP3, which is called inflammasome pathway. Now, this chronic meta-inflammation ultimately, by affecting these 4 organs, will end up into diabetes and insulin resistance. Remember, liver, we have liver, pancreas, adipose tissue, and muscle. So when you eat extra fat, these 4 are involved. These 4 will ultimately end up into diabetes. Therefore, inflammation leads to diabetes. Treatment of diabetes is at source, treat at source inflammation by targeting inflammatory pathways and not consuming sugary items. Therefore, the role of our supporter of this CME grant, Energal Zero, comes in. Coming back to a line about leptin and adiponectin. So adiponectin reduces, leptin increases. So these are also used as a markers as well as a therapeutic options. This is leptin, which is a inflammatory in nature, and this is low adiponectin, which is also responsible for inflammation. And this is a study by Dr. Siddharth Shah, which has clearly shown that in diabetics, adenopectin reduces and nuclear factor kappa beta pathway increases and CRP increases. So this shows that if you want to treat the inflammation, you attack the CRP, you increase the adiponectin, or you reduce the nuclear factor kappa beta. These pathways are available, tests are available. So adiponectin is reduced in obesity, insulin resistance, and diabetes mellitus. Adiponectin is anti-atherogenic and anti-inflammatory, and adiponectin insufficiency is also associated with procoagulative phase. And so therefore this procoagulative phase and pro-inflammatory phase, according to a study by Dr. Siddharth Shah, is also involving IL-17, and coagulative profile is deranged in diabetes because of inflammation. Coming back to the marker, the clinical marker is CRP, but you can check for TNF alpha, you can check for kappa beta pathway, blood test, you can use the Dr. Siddharth Shah has done, but the clinical markers of inflammation is CRP. So if your CRP is high, ask yourself, am I obese? How will you decide you are obese? You will check for weight gain after the age of 18. If it is more than 5 kg, or if you have a visceral obesity, that means your abdominal circumference is more than half of the height, or if you have fatty liver on ultrasound, you know you have a low grade systemic inflammation because of adiposity, then start looking for parameters of meta inflammation and metabolic syndrome. And at that particular moment, you will find that you may be in a stage of impending diabetes. Impending diabetes means your HbA1c may be less than 6.5, but more than 5.9, which indicates that you already have started meta-inflammation. If you start treating your diabetes at a meta-inflammation stage, you may prevent a diabetes. And if you are a diabetic, if you start treating the inflammation, you may reduce the dose of the insulin, you may reverse the diabetes also. If somebody says, can I reverse the diabetes? Answer is yes, if this diabetes is due to meta-inflammation. So meta-inflammation leading to diabetes can be reversed. But if there is a permanent damage, then you can't do anything. Insulin resistance can be reversed, meta-inflammation can be reversed. Therefore, if you want to reverse diabetes, it cannot be done by just controlling the blood sugar. You have to go to the root cause of high blood sugar. And the latest is inflammation, inflammation, and inflammation. This is a subject we will discuss in great detail, that which are the anti-inflammatory drugs which can be effective apart from the anti-diabetic drugs. Aspirin, methotrexate, TNF alpha blockers, antioxidants, IL-1 beta antagonists, which are NLRP pathway, colchicine, hydroxychloroquine, which is now approved in India, metformin, glitazols. All of them SGLT2 inhibitors, all of them also have some degree of anti-inflammatory action. So if you are treating a patient with diabetes, also look for underlying inflammation and treat it. So the message for today is treat the patient and not the blood sugar. And when a patient has a blood sugar, hypertension, hyperlipidemia, atherosclerosis, or if the patient has both micro and macrovascular disease, take it for granted the patient has underlying meta-inflammation. Treat, intervene meta-inflammation also. So I'll give you a classical example before I end. We lost Rajiv Kapoor, our film hero, couple of days back. His elder brother Randhir Kapoor said, उन्हें कोई बीमारी नहीं थी, he had no disease, he was healthy, he was everything. But nobody saw his picture. You see him walking, he was obese. So he was having meta-inflammation. And that meta-inflammation was missed. And if you don't treat meta-inflammation, you can end up with sudden cardiac event. So the diagnosis in each case was, because his brother said he was hell and healthy, he has no disorder, he was absolutely fine. That means a meta-inflammation was missed. So obesity with meta-inflammation will end up into diabetes. So prevent diabetes by meta-inflammation and reverse diabetes by also acting on meta-inflammation. That was the subject of today. And remember that if you want to refresh with Enerzal Zero, which is nothing but a refreshing non-sugary drink. because there is no way you can refresh yourself with a inflammatory drink. You need non-inflammatory drink. An apple a day keeps a doctor away because apple contains pectins which are anti-inflammatory in nature. Kada, whatever kada you are drinking today is nothing but anti-inflammatory diet. Remember, ka for kadwa, ka for kasela, ka for karela, ka for kalmek, ka for kachi haldi, ka for colchicine, का फॉर के कहते हैं कि का फॉर कोरोना, का से कोविड बचने के लिए आप कड़वा कसेला एंटी इन्फ्लेमेटरी डाइट को लीजिए और इन्फ्लेमेटरी ड्रिंक्स को मत लीजिए. Let's have the question of this week. It's a very simple. If you have heard me carefully, attentively, this is a very simple answer. Which of the statements given below is correct? Immune cells like macrophages infiltrate pancreatic cells, releasing pro-inflammatory molecules in diabetic individuals. Both circulating and cellular biomarkers underscore that diabetes is a chronic inflammatory disease. Chronic complications linked to diabetes include only microvascular complications. Diabetes does not affect the cardiovascular system. I think this is the gist of my talk, which I have given in great detail, explaining all three in great detail. That's all for today. Over to Shalenji, and we will be back next week again. Shalen Minaji.
Thanks a lot, sir. That was a most wonderful session. You have explained the paradigm shift. I would say you have brought a paradigm shift in our understanding of diabetes. You have explained the very basic concept why the diabetes is happening, low grade systemic inflammation or meta inflammation. And the way you have explained this complicated topic so simplistically, only the best teacher like you can do it, sir. It was a very wonderful session. And I would like to thank all the audience also for taking out time and joining us. We will be back again next week. So please do join us same time. Thank you very much. Have a good night.
Thank you.
Thank you, sir.